In fact, this is what happened. When they wrote books on non-cirrhotic fibrosis, Dr. A.K. Basu, who was the most famous surgeon in Calcutta, who worked on this thing, Dr. Aiker at that time had, and the surgeon, as I told you, when they take a wet biopsy, they will take it from the undersurface. And in fact, the undersurface always shows more nodules than the other surface. So Dr. Aiker got the undersurface wet biopsy, and he called that as cirrhosis. They wrote a book on it. Then, by that time, just after that time, we had been looking at it and we found a difference. So they had called a big conference in Chandigarh where I presented my data and said that this is what. And Dr. Aiker, of course, was a great guru of mine and he loved me and very much. So Dr. Basu, I remember at the night when we were staying in the guest house, Dr. Basu brought Aiker with him to my room and said, Aiker, what did you do? You took me to all pieces. Look at my, how are you doing it? So this is just a problem of sampling. That's all that I have. You gave me bad samples. It's not important. But the point is, I want you to make aware. Now, in the same case, as we go deeper into the parenchyma, see what has happened. This part of the liver is looking normal, more normal and normal. And if your needle passes like this, it will catch a normal. In fact, when a clinician suspects portal hypertension and is not sure whether he has cirrhosis or non-cirrhosis, whatever it is, he does a needle biopsy. If you see a normal liver, but he has definite evidence of portal hypertension, his age is the right for NCPA, these things, etc., gradients are right and all that, you can say comparatively because that is the only condition where a deep needle biopsy can look entirely normal. Okay. The cholestasis will first occur in the centrizonal area in the canaliculi. I hope you all know what are canaliculi, what are tubules, and what are ducts. So in the canaliculi is not a separate duct, it's a part of the liver cell. It's a half moon type of space on one side liver cell, another half moon type of grooved out thing in the other side liver cell. When they join, they make a tube. So it's a chicken neck type of tube which go and join each other and form a duct tube and then a duct. So if you find canalicular cholestasis mostly in this area, early part, that's the extra hepatic obstruction. When that advances, you can get additional changes in the portal bile ducts, that is inflammation, etc., because it is superadded infection. If there is no superadded infection, this is the change you will get. So you can suggest from the liver biopsy that for some reason this patient must be having an extra hepatic. That's a neonatal. Again, you know, one of the important problems the pediatrician will give you, or the pediatric surgeon will give you, is to differentiate between neonatal hepatitis and biliary. Because one needs a very strong surgery, the other one doesn't need anything at all, no drugs, nothing. So you have to distinguish and tell them whether it is neonatal hepatitis or biliary. And on your diagnosis, they will start doing the surgery. And it's quite an extensive surgery, as you know. So this patient, you see here, this neonatal hepatitis is also called giant cell hepatitis. I hope you people know. Now, this one here, there are lots of, these are all hematopoietic cells. Because hematopoietic cells normally stay in the infant liver for about at least 1 week or so, in good amount, and then they gradually reduce down and disappear. So the hematopoietic cells are persistent. There is some cholestasis, and there are some, these are not foreign body giant cells or Langerhans giant cells or tumor giant cells. So there is another type of giant cell that is hepatocytic giant cells. And that is why this was more
really, I thought that I am in 1970 doing a post-grad study. I'm in the middle. SAR is 1880s. My age is senior to my professor Naik. And I am in 70s. 1 year senior. 1 year senior. And our other chairperson is in 50s. So I am in the middle. I the person, Dr. Mahapatra, I like him very much, and he's he's to go for another 12 to 13 years. We expect a lot of from him, and I just invite the chairperson just to conclude this.
So it was very hard to believe that Professor Nayak at the age of this can stand here for 2 hours and go on for a lecture like this. All the time I was just observing about postural hypotension. My God, at my age. Right. So there is it's a huge message for all of us. It takes science. So this is something that we can do. Initially when we became lecturers, we say 1 hour class theory, we'll be tired. Look at this man. He is an inspiration for all the Homo sapiens in the world. His brain, his stamina, his inspiration, his acumen, his sharpness, his thirst for knowledge. At this age, he wants to learn, he wants to teach, he wants to share the knowledge. What more can this talk can give you? Thank you so much, sir. Thank you so much.
To the rare case studies presentation by our next enthusiastic speaker, Dr. Anna Pulimur. She had earlier given us the cases and we have worked it up and we are all eager to know how far we reached.
Most of them should be easy for you because I showed you pictures of this earlier on, but anyway, we start. The first one was a 54-year-old lady with chronic renal failure. She had peptic symptoms. An upper GI scopy showed multiple ulcers, 1 centimeter size, with clean bases and flat regular margin. Biopsies are from the esophageal ulcers. Okay, you all see the normal squamous cell, squamous mucosa here, and here is the exudate. This is the edge of the ulcer. Here you see actually this is a vesicle. Here in the epithelium, there is some necrotic material and acute inflammatory exudate. There is a vesicle here, and this is the edge of the ulcer. This one looks a bit abnormal, so we look at that closer, and this is what we are seeing. So any guesses? Corpus simplex. Why? Are you seeing a typical Cowbry type A intrusions? Why? In the later stage of herpes, the typical intrusions with the halo around it, they disappear. There's only a pale eosinophilia in the nucleus. Okay, the whole nucleus inside will look eosinophilic, and also a ground glass appearance. I'm not sure you can make that out here. Some of these nuclei, inside them there's a ground glass appearance. This is the end stage of herpes infection. The other thing you can see is that there are multinucleate cells. Here, this one, can you see the multiple nuclei inside the cell? Here. And this is called nuclear molding. So the multinucleate nuclei, the multiple nuclei, they all fit into a kind of mold. So they are all next to each other. That's called nuclear molding, and inside the nucleus there's an eosinophilia. So this is a herpetic esophagitis. Again, another section showing, see, an eosinophilic nucleus. Normal epithelium at the ulcer is where you see the typical herpetic lesions. So if you look at esophageal ulcers, the most common ulcers are because of reflux esophagitis. But many infections like herpes and CMV can cause ulceration. tuberculosis also. Various drugs, iron tablets, colchicine, these can cause esophageal ulcers. Various dermatological conditions. Again, if you see a vesicle or an ulcer and you can't find a reason, ask the clinician whether the patient has any change reaching up to the muscularis mucosa. If many crypts are pointing in different directions, okay. Now sometimes in a biopsy, because of twisting of the biopsy, crypts may be bent a little bit. But then you will see that they may be bent in the direction of the twisting. So if it is twisted in that way, the crypts will be like that. But if the crypts are all in different directions, it can't be because of twisting, and that is genuine crypt disarray. Okay, so now in this one, I feel there is genuine crypt disarray because some of the crypts are pointing in that direction. Now this one is pointing in this direction. This one is pointing in that direction. This one is going in this direction.
Since it's already 5 o'clock, we'll go to the last session of this today's function, that is the validation function. And I invite Professor K.C. Sharma to please come to the dais. And I invite Professor Salva to please come to the dais. And may I invite Dr. P.K. Sarwani to please come to the dais. And Professor B.S. Acharya, please come to the dais.
ସବୁବେଳେ ବାହାରୁଛି ଆମ ଓଡ଼ିଆ ଭାଷାକୁ କେହି ପଚାରୁନାହାନ୍ତି, ଆଉ କେହି ପଢ଼ଉନାହାନ୍ତି। କଲେଜରେ ସବୁ ଓଡ଼ିଆ କୁଆଡ଼େ ପଳେଇଗଲାଣି। ତମେ ଯଦି ସତରେ ଟିଭିରେ ଦେଖୁଥିବ କିଛି ଦୂରସଞ୍ଚାରରେ କିଛି କାର୍ଯ୍ୟକ୍ରମ, ସେ ପୁଣି ଓଡ଼ିଆରେ ହେଉଛି, ଯିଏ କହୁଛି ପ୍ରତ୍ୟେକ ବାକ୍ୟରେ 3ଟା ଇଂରାଜୀ ଶବ୍ଦ ନ କଲେ ତାର ବାକ୍ୟଟା ପୂର୍ଣ୍ଣ ହଉନି। ଏଇଥିରୁ ଜଣାଯାଏ ଆମେ ଓଡ଼ିଆକୁ କେତେ ଭଲ ପାଉ ଆଉ ତାକୁ ବଞ୍ଚେଇ ରଖିବାକୁ କେତେ ଚେଷ୍ଟା କରୁ। ମୁଁ ଜାଣିନି ଆପଣମାନେ ସବୁ ଖଣ୍ଡଗିରି ଉଦୟଗିରି ଯାଇଛନ୍ତି କି ନା? ଭୁବନେଶ୍ୱର ପାଖରେ ପାହାଡ଼ଟେ ଗୁଡ଼ାଏ ଗୁମ୍ଫା ଅଛି। ଖଣ୍ଡଗିରି ଗୋଟେ, ଉଦୟଗିରି ଗୋଟେ। ଯଦି ଖଣ୍ଡଗିରି ଯାଇଥିବେ, ଗୋଟେ ହାତୀ ଗୁମ୍ଫା ଅଛି। ହାତୀ ଗୁମ୍ଫାର ଉପରେ ପାହାଡ଼ ଦିହରେ ପଥର ଦିହରେ କିଛି ଲେଖା ହେଇଛି। ସେଟାକୁ ପଢ଼ନ୍ତି, ଆମେ ଜାଣିଲେ, ଆମକୁ ପଢ଼ି ଆସେନି, ଆମେ ବୁଝିପାରିବାନି। ସେଇଟା ହେଲା ପାଲି ଭାଷା। ଖାରବେଳ ହରିକାଙ୍କ ସମୟରେ ପାଲି ଭାଷା ବୋଲି ଗୋଟେ ଭାଷା ଥିଲା। I'm sorry, ପାଲି ଭାଷା ବର୍ତ୍ତମାନ କୁଆଡ଼େ ପଳେଇ ଯାଇଛି। ଆମ ଭିତରୁ କେହି ପାଲିରେ କହିପାରିବେନି, ବୁଝିପାରିବେନି ନା ପଢ଼ିପାରିବେନି। ଏମିତି ଗୋଟେ ଭାଷା ଥିଲା କି ନାହିଁ, ମୁଁ ଜଣେ କହିଲେ ମୋ ରାଷ୍ଟ୍ରୀୟ ଭାଷା କହିବ ଏଇଟା କ'ଣ ଗୋଟେ ଗପୁଛନ୍ତି ମିଛ କଥା। ସେମିତି ମୋତେ ଲାଗେ, ଅସମ୍ଭବ ନୁହେଁ। ମୋ ନାତୁଣୀର ଛୁଆ ହେଲା ବେଳେ ସେ କହିବ ଓଡ଼ିଆ ବୋଲି ଗୋଟେ ଭାଷା ଥିଲା। ଅସରନ୍ତି ଆଉ ତାର ସାଙ୍ଗମାନେ ଯେମିତି ଭାବରେ କଲେ, ୟାଠୁ ବୋଧେ ଆଉ ଭଲ ହେଇପାରେ। ଆରମ୍ଭରୁ ହେଲା ଜଳଖିଆ। ଜଳଖିଆଟା ଏତେ ଭଲ କରିଥିଲା, ସେଥିପାଇଁ ସମସ୍ତଙ୍କୁ ଧନ୍ୟବାଦ। ପୁରୀକୁ ପୁରୀ, ତା ସାଙ୍ଗରେ ଥିଲା କ'ଣ ଇଡଲି ଥିଲା, ସମ୍ବର ସାଙ୍ଗରେ ଆଳୁ ଆହୁରି ବଢ଼ିଆ, ମିଠାର ରସଗୋଲାଟା ବହୁତ ଭଲ ଥିଲା। ଖାଇବାଟା ବହୁତ ଭଲ ହେଇଥିଲା ଜଳଖିଆ। ତାପରେ ଆମେ ଆରମ୍ଭ କଲେ ମ୍ୟାଡ଼ାମଙ୍କର, ଆମ ମୁଖ୍ୟ ଅତିଥିଙ୍କର ଭାଷଣ। ମୁଖ୍ୟ ଅତିଥିଙ୍କ ଭାଷଣ এইটা বিশেষ করে। She was so good, so lucid, so talented, and such a lovely presentation possibly I have never heard so far. Thank you, madam. She looks so beautiful in her appearance. Her presentation was much better than what her appearance is. Giving my introduction, I said to her, when I was introducing her, I said, late Radhakrishnan, our past president, Dr. Abdul Kalam, they did not, they are never introduced by their village etc. They were known as a great philosopher and a desired man of India. I said, she also does not live like them, meaning I compared her with those people. And nicely, effectively, she has presented that presentation exactly as possibly, I said, like Radhakrishnan or Abdul Kalam. I have heard both of their lectures. When I was taking my undergraduate degree, Radhakrishnan came to the university, came to this vocational address. He was the chief guest. He gave 15 minutes only. That was enough to learn a lot of things. Similarly, I have heard Abdul Kalam many times at Attack as well as Bhubaneswar. Her presentation, I say, it was difficult and equally good as both of them. Thank you, madam, such a lovely presentation. Again, once more. Then there was presentation by Professor Naik. I will just mention few sentences about Professor Naik. Professor Naik's cousin brother was my classmate from class 4. I used to go to their house quite frequently. Oh, brief okay. Professor Naik could anything I knew because of his cousin brother, and subsequently he became a teacher of mine in pathology department. Thrice I have come in contact with him. First time I was having a lot of cough and cold. I thought that I was having tuberculosis. That was in my third year. No other disease I have had enough. Cough and expectoration with fever means TB. So I thought that I had it. Professor Mishra, Sarath Mishra was the medicine professor. He sent me for a DC and I thought that this doctor does not know anything. I am having TB, he is asking for it. He should have asked me for a chest X-ray. But anyway, I went to Professor Naik. He told me that you go to such and such, he will make a smear, stare it and bring it to me. I brought it. And he reported within a minute's time that I still remember, I had 67% of eosinophils. I thought, Sarah's blood. How can he make it 67%? During that time, in our class, we were having a BC slide. We used to have a square, then 100 numbers, 490 N, and E. It was taking 5 minutes for one slide, many more. So how could he make it? Sir must have come. Naturally. In one of his classes, during those days, he was taking our clinical pathology class. And I thought in the undergraduate class, I will be like Professor Naik. What is Professor Naik to me? Professor Naik to me was like Brahma Vilivariyatam. We say Lord Brahma, when in sleep he chants something that comes from the Veda. So Professor Naik, whatever he will speak in such an authentic tone, and you must have heard the tone when he was speaking. That Brahma, whatever he speaks, that is pathology, nothing else is pathology. He may be wrong or right, you don't. You feel that that is the correct one. So that is Brahma. I tried. At least, I do not know. I have never been, I am sure. But I tried to be, at least develop his tone. In an emphatic way, speak something completely wrong, at least others will feel that he is saying whatever he is telling is right. So I missed. But I am sure the lunch must have been excellent. which I have missed. I will wait for the next CME to patch up the line. And all the program was so good, all imaginable, excellent. Thanks to all the people who have participated, and thanks all the people who have organized so beautifully nice. Thank you very much.
I have already told in detail, and I will only speak a few words, speaking in English. Though I know very good Oriya. Very well. Now, I can only say that it was very crisp, and everything was put up for both postgraduate students, staff who report, and there are no undergraduate students, but undergraduate students who have already also enjoyed the lectures. Because I am like an undergraduate student in gastroenterology, though I was reporting in between gastric biopsies and all those endoscopic biopsies, but I am like an undergraduate student, and I could learn quite a lot from both the lectures. So I am sure all the postgraduate students and staff members who are reporting must have wiser today.